Hello, everybody. I hope all is well. And now we start the second part of oral medicine um, department by Dr. Mina Khayyamzadeh. She is assistant professor of oral and maxillofacial medicine department, Tehran University of Medical Science. The topic is orofacial pain. Hello, Dr. Khayyamzadeh. Thanks for joining us. Please start. We are happy to listen to you.
Hello everyone and welcome to my presentation. Let me thank you all for coming to this program. First of all, let me start by saying a few words about my own background. I am Dr. Mina Khayyamzadeh and oral medicine specialist and assistant professor of oral medicine in Tehran University of Medical Science. As you see on the screen, our topic is orofacial pain. In my presentation, I will focus on three major issues. One, pain. Two, orofacial pain. And three, chronic orofacial pain. First of all, we must know what is pain. Pain is a multifaceted experience involving physical, cognitive, and emotional aspects. Pain has been defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. One of the classification of pain is acute and chronic. Acute pain is a type of pain that typically lasts less than 3 to 6 months, or pain that is directly related to soft tissue damage, such as a sprained ankle or a paper cut. Pain is of short duration, but it gradually resolves as the injured tissue heals. Nociceptive pain is a medical term used to describe the pain from physical damage or potential damage to the body. Examples might be the pain felt from sport injury, dental procedure, or arthritis. Nociceptive pain is the most common type of pain that people experience. It develops when the nociceptive nerve fibers are triggered by inflammation, chemicals, or physical events, such as stubbing a toes on a piece of furniture. Nociceptive pain is usually acute and develops in response to specific situation. It tends to go away as the affected body parts heals. For instance, nociceptive pain due to broken ankle gets better as the ankle heals. The body contains specialized nerve cells called nociceptors that detect things that could damage the body, such as extreme heat or cold, pressure, and chemicals. These warning signals are then passed along the nervous system to the brain, resulting in nociceptive pain. This happens very quickly in real time, which is why people need to remove their hands if they touch a hot oven or take the weight of an injured ankle. The information provided by nociceptive pain can help the body protect and heals itself. Nociceptors can also be found in the internal organs, although their alarm signals are less easy to pinpoint and may not always be felt. The information provided by nociceptive pain can help the body protect and heal itself. This slide is for rest, journey through a neural cell network inside the brain, and I think it's wonderful. Okay. new term used to describe a pain that develops when the nervous system is damaged or not working properly due to disease or injury. It is difficult for nociceptive pain because it does not develop in response to any specific circumstances or outside stimulus. Neuropathic pain is also referred to as nerve pain and is usually chronic. What is phantom limb pain? Individual can suffer from neuropathic pain even when the aching or injured body part is not actual there. This condition is called phantom limb pain, which may occur in people after they have had an amputation. As you see in this slide and the pictures, many different conditions and the diseases causes the pain, neuropathic pain, including diabetes, multiple sclerosis, stroke, cancer, cytomegalovirus, and amputation. People with diabetes are advised to watch for symptoms of neuropathic pain, particularly in their feet. Neuropathy in the lower limbs is very common in people with diabetes and is a leading cause of amputation. Neuropathic pain in people with diabetes often begins with numbness, weakness, or burning in the toes. This pain can also get worse at night and make it difficult to sleep. The most common areas for people to experience nociceptive pain are in the musculoskeletal system, which includes the joint, muscle, skin, tendons, and bone. Internal organs such as the intestine, lungs, and heart can also be subject to nociceptive pain, along with the smooth muscles. People with diabetes can also develop neuropathy uh, in other parts of the body, including near the eyes and the wrists. Many people with cancer experience neuropathic pain in back, legs, chest, and shoulders due to tumors affecting the spinal cords. They may also experience neuropathic pain due to medication or surgery. The lower back is one area where individuals can experience both neuropathic and nociceptive pain. It is important to keep in mind that an individual can experience neuropathic and nociceptive pain at the same time. Paying attention is the key differences can improve the quality of life for people dealing with pain and help them get the correct treatment. As nociceptive pain can develop anywhere on the body in response to heat or trauma, it can have many different characteristics. It is usually most severe at the time of injury, but may also be worse first thing in the morning or during activity. People with neuropathic pain report a variety of symptoms, including sharp, shooting, searing, or stabbing pain, tingling sensation, numbness, extreme sensitivity to touch, insensitivity to heat or cold, muscle weakness, and so on. This slide is a forest as well, beautiful flowers and butterflies. Orofacial pain. Orofacial pain is prevalent in general population, around 23%, of which 7 till 11% is chronic. Acute orofacial pain is primarily associated with teeth and their supporting structures. Most frequently, dental pain is due to dental caries, although broken filling or tooth abrasion may also cause dental sensitivity. Other oral pains are usually periodontal or gingival in origin. Painful regional syndrome with a chronic unremitting pattern. Generally, the pathology of orofacial pain is most commonly caused by the diseases of the teeth that we say odontogenic pain, which is a domain of dental medicine, and it should not be a diagnostic therapeutic challenge in itself. What is chronic orofacial pain? Clinically, chronic orofacial pain may be subdivided into three main symptomatic classes: musculoskeletal, neurovascular, and neuropathic. Musculoskeletal is classified to masticatory muscle tension type headache and TMJ disorders. That my colleagues will have lecture about TMJ disorders and masticatory muscles. Neurovascular pain include trigeminal autonomic cephalgia and migraines. Trigeminal autonomic cephalgia are primarily headache with a common clinical phenotype consisting of trigeminal pain and autonomic sign that we say AS, and including cluster headache or CH. Paroxysmal hemicrania, short-lasting unilateral neuralgiform headache attacks with conjunctive injection and tearing, and short-lasting unilateral neuralgiform headache attacks with cranial autonomic fissures. Neuropathic pain that is very important for us is divided to trigeminal neuralgia, glossopharyngeal neuralgia, painful post-traumatic neuralgia, and burning mouth syndrome or PMS. The current pathophysiology model attempts to explain the three major features of the trigeminal autonomic cephalgia. Trigeminal pain, the first one; second one, rhythmicity, particularly in CH, and AS, autonomic sign. Taken together, current data suggests that CH and other trigeminal autonomic cephalgia are conditions whose pathophysiology basis is in the central nervous system, including the hypothalamus that drives the initiation of the clinical phenotype. I choose cluster headache and paroxysmal hemicrania. Cluster headache is the archetype. Trigeminal autonomic cephalgia with severe pain and major autonomic activation. Cluster headache typically appears between the age of about 20 till 29 years. Is more common than previously thought and seems to affect men more than women. Episodic cluster headache commonly occurs at least once daily for a period of weeks at the same time of day or night. Pain in cluster headache is usually periorbital or ocular, but varies. In upper cluster headache, the forehead, temporal, and parietal regions are involved. Whereas in lower cluster headache, the temporal and suboccipital regions are affected with radiation to the teeth, jaws, neck, and cheeks. Pain is unilateral, and 20% of cases may change sites. Attacks alternate sites more commonly between cluster and between attacks in the same cluster. Paroxysmal hemicrania. In paroxysmal hemicrania, mean age of onset is usually between 34 to 41 years, but children age 6 and adults age 81 years have been reported. The episodic form is considered to have an earlier mean age of onset, 27 years, than the chronic form, 37 years. Only 20% of paroxysmal hemicranias behave episodically, and many of these eventually develop into chronic forms. Paroxysmal hemicranial is a unilateral, severe orbital or periorbital pain, and the vast majority of attacks do not change side, but a strong pain may cross the midline and very rarely becomes bilateral. It occurs in temporal, perioauricular, maxillary, and radio-occipital areas. Neuropathic orofacial pain included a number of clinically entities. The most common are trigeminal neuralgia, painful post-traumatic neuropathies, and burning mouth syndrome. More rarely, facial post-herpetic neuropathy and central post-stroke pain and glossopharyngeal neuralgia are encountered. Neuralgia refers to a severe pain which occurs due to an irritated or damaged nerve. This condition is more common in the elderly, but it can affect anyone at any age. What are the symptoms of neuralgia? The symptoms of neuralgia usually include acute pain. Uh, this is the main symptom of neuralgia and presents as a very intense pain felt throughout the area of the affected nerve. More sensitive skin in the region of the nerve that leads to intense pain with contact. Muscle weakness where the nerve is located. Sometimes the muscle also becomes temporary paralysis. The cause of some types of nerve pain is not completely understood. You may feel nerve pain from damage or injury to a nerve, pressure on a nerve, or change in the way the nerve functions. The cause may also be unknown. Infection can affect your nerves. For instance, the cause of post-herpetic neuralgia in shingles, an infection caused by the chickenpox virus. The likelihood of having this infection increases with age. An infection in a specific part of the body may also affect a nearby nerve. For instance, if you have an infection in a tooth, it may affect the nerve and cause pain. Multiple sclerosis is a disease caused by the deterioration of merely. Trigeminal neuralgia may occur in someone with MS or multiple sclerosis. Pressure on nerves or compression of nerves may cause neuralgia. The pressure may come from a bone, ligament, blood vessels, tumors, and the pressure of a swollen blood vessel is a common cause of trigeminal neuralgia. Another factor is diabetes. Many people with diabetes have problems with their nerves, including neuralgia. The excess glucose in the bloodstream may damage nerves. This damage is most common in the hands, arms, feet, and legs. Less common causes are chronic kidney disease, medication prescribed for cancer, fluoroquinolone antibiotics used to treat some infections, trauma, such as from surgery and chemical irritation. Trigeminal neuralgia is very important for in oral medicine, and I prefer to speak more about this neuralgia. Trigeminal neuralgia is an short-lasting unilateral facial pain. The most common is the classical that is unrelated to pathology and most probably caused by neurovascular compression of the trigeminal nerve root. In the new classification, secondary forms have been classified separately, and these are related to a variety of clear pathologies, including tumors, cysts, viral infection, trauma, and systemic diseases such as MS or multiple sclerosis. The vast majority of trigeminal neuralgia, more than 85%, are diagnosed with classical trigeminal neuralgia or CTN. Recent evidence suggests that most cases of CTN result from the compression of the trigeminal neuralgia, trigeminal nerve by a vascular malformation. Recognized by the current classification are trigeminal neuralgia cases that present with a continuous background pain in addition to the typical pain paroxysm. Up to one-third of patients, about 4 to 75%, describe typical paroxysmal attacks on a background of dull, persistent pain of varying duration. Characterized trigeminal neuralgia characterized by paroxysmal pain in trigeminal dermatomes, most commonly in both the maxillary and mandibular branches of the trigeminal nerve, about 35%. In 36 to 42% of cases, classic trigeminal neuralgia affects one branch. 16 to 18% each in the maxillary or the mandibular branch, 2% in the ophthalmic branch, and all three branches is about 40% of patients. Classic trigeminal neuralgia is strictly unilateral, and pain radiation is generally within the dermatomes of the origin. Bilateral cases are extremely rare and begin unilaterally, preceding the onset of contralateral pain by years. Pain is paroxysmal, shooting, sharp, piercing, stabbing, or electrical pain. Pain episodes are identical in location, duration, and intensity within individuals. Trigeminal neuralgia is characterized by spontaneous remission lasting weeks to years, but approximately 20% of trigeminal neuralgia patients suffer daily attack with no respite. Majority of trigeminal neuralgia patients, about 90%, report increased attack frequency and severity. An attack begins and ends abruptly, lasting from a fraction of a second up to 2 minutes. Longer attacks increasing with disease duration have been reported. The pain are usually accompanied by spasms of the facial muscles. Typically, pain indicated by light touch, as cited, called trigger areas. Many attacks are spontaneous, and triggers in the areas are not always clinically identifiable. Trigger areas are usually the distribution of the affected trigeminal branch, usually the lips, but may be extra trigeminal, may be multiple, and may change location. Trigger factors such as noise, lights, and stress may also induce pain. There are two attack-related phenomena that are particular to trigeminal neuralgia. Latency refers to the short period of time between the stimulation of a trigger area and pain onset. A patient with classic trigeminal neuralgia complain of sensory loss, sophisticated content background. An early form of trigeminal neuralgia, termed pre-trigeminal neuralgia, has been reported in 18% of trigeminal neuralgia patients and is characterized by a dull, continuous pain days to years in one of the jaws. As pre-trigeminal neuralgia progress, it becomes more typical with characteristic flashes of pain. Thermal stimuli may cause triggering at a relatively higher rate and a throbbing quality to pre-trigeminal neuralgia pain is sometimes present mimicking dental pathology. Indeed, these qualities combined with the success of regional anesthesia have led to misdiagnosis of pre-trigeminal neuralgia as pain of dental origin. As glossopharyngeal neuralgia is rare and is not common, I prefer to explain about BMS that is more common and very important in oral medicine. BMS or burning mouth syndrome is a poorly understood pain condition that is more probably neuropathic. The condition is also known as stomatodynia and is characterized by burning mucosal pain with no significant physical sign and is common in post-menopausal women. PMS may be subclassified into primary or idiopathic BMS for which a neuropathological cause is likely and cannot be attributed to any systemic or local causes, and secondary BMS resulting from local or systemic pathological condition. BMS is unfortunately characterized by resistance to a wide range of treatments and is one of the most challenging management problem in the field of orofacial pain. What is the clinical features of BMS? The tongue, usually the anterior part of the tongue. However, usually more than one side is involved, and in addition to the tongue, heart, palate, lips, and gingiva are frequently involved. Pain is most commonly described as burning, and intensity varies from mild to moderate or to severe. EMS is typically of a spontaneous onset and lasts from months to several years. The pain pattern may be irregular, but some patients may complain that pain increased toward the end of the painful post-traumatic trigeminal neuropathy. In some patients, develop chronic pain following negligible nerve trauma, such as root canal therapy, or following considerable injury to nerve bundles, such as in fracture of the facial skeleton. Following dental implant surgery between 1 to 8%, and following orthodontic jaw surgery between 5 to 30% of patients may remain with permanent sensory dysfunction, but the incidence of chronic pain is unclear. Third molar extraction may lead to disturbed sensation in the lingual or inferior alveolar nerve for a varying period in 1% of cases, but follow-up failed to identify any neuropathic pain cases. Patients complain of tongue after injury may remain in a small group of patients. Persistent pain after successful root canal therapy was found in 3 to 30% of cases, whereas surgical root therapy resulted in chronic neuropathic pain in 5% of cases. Following the identical injuries, onset of neuropathic pain and its characteristics vary from patient to patient. Such variability is probably due to a combination of environmental, psychosocial, and genetic factors. The presence and duration of pain in the tooth tenderness to percussion, female gender, previous painful treatment in the orofacial region, and so on. Chronic pain issues are possible risk factors for the development of chronic pain following successful root canal therapy. I sincerely appreciate your attention. Thank you very much.
Um, thank you very much for your nice presentation. And now, if a student have any question, we ask from you. Um, One question is that in a patient which is represented alopecia areata from more than 10 years, patient had good oral hygiene and all teeth are healthy, but express acute pain in maxillary jaw, especially involves maxillary molar.
Excuse me, would you mind repeat again?
Yes. Sorry. Uh-huh.
First
Yes.
of all, can I answer the question?
Yes, yes, yes.
First of all, we must see the teeth and examine the teeth of the patient. After that, because the most common cause of pain in oral and orofacial pain is odontogenic pain. So we must first rule out the caries, periodontal diseases, and so on. And after that, we examine other parts of the body for neuropathic pains.
Okay, thanks very much. Another question is that if the patient has an acute pain in certain area of the mouth for a while, can this pain transfer to chronic pain?
As I told you in before question, the most cause of the pain in the mouth is odontogenic diseases, and usually the acute pain is odontogenic disease. So it is not if we treat the odontogenic problem, this acute pain, we can treat acute pain.
Okay, thanks a lot for your presentation. Have a good time.
Thank you very much.
Yeah. In the name of the Most High, شروع کنم؟ زدم. شروع کنم. In the name of the Most High, I'm Dr. Maryam Kupai, Assistant Professor of Oral and Maxillofacial Medicine, Tehran University of Medical Science. I want to present a case for you. A 54 years old man was referred to dental faculty of Tehran University of Medical Science just for restorative treatment of first right maxillary incisor. But in intraoral examination, we noticed an ulcer with regular border in right maxillary tuberosity, distal to first molar. Evidence of bone loss in first right molar was seen, but there was no purulent discharge. Other sites of the attaching gingiva were within normal range, and panoramic and periapical examination showed no evidence of generalized alveolar bone resorption. You see an ulcer in the maxillary tuberosity distal to the first maxillary molar. The ulcer is with regular border. And in this picture, you see evidence of fenestration and bone loss in right first molar. In a past medical history, patient doesn't have any significant medical disease, but patient had a history of eating rough bread. Hence, regarding the possibility of trauma, we prescribed soft diet for patient and followed him 14 days later. There was no evidence of wound healing after 14 days. Hence, incisional biopsy was done. Okay, what is your differential diagnosis? Please type your differential diagnosis in the chat box for me. اون که دست بلند کرده میشه. Yes, this was the case. As you see, an ulcer in maxillary tuberosity. The patient was unaware of having an ulcer in his mouth. Don't you have any idea about the differential diagnosis? And you see evidence of fenestration and bone loss on the first right molar. The lesion wasn't painful, and as I say, patient doesn't have any patient doesn't know about presence of ulcer in his mouth. Patient just referred for treatment of his maxillary incisor for restorative treatment, and the lesion was seen in oral examination. Okay, the differential diagnosis of the lesion. The first differential diagnosis is traumatic ulcer. For traumatic ulcer, the patient has a past history of injury, and the extent of the ulceration depends on the agent involved, and the site depends on the activity involved. The second differential diagnosis is squamous cell carcinoma. You must know that squamous cell carcinoma is always in the differential diagnosis for non-healing ulcer. As such, all ulcers present for 2 to 4 weeks with little evidence of healing should be biopsied to rule out squamous cell carcinoma. The other differential diagnosis is CMV or EBV infection, which occur most commonly in immunocompromised patients, and also deep fungal infections that occur in immunocompromised patients. So we had 4 differential diagnoses for this lesion. Incisional biopsy was done for the lesion, and histopathologic analysis showed a malignant epithelial neoplasm composed of epithelial islands that demonstrate prominent nuclear polymorphism and keratin pairs formation invading subjacent connective tissue. Severe chronic inflammatory cells was notable, and these histologic features was compatible with squamous cell carcinoma. So the diagnosis of the lesion was squamous cell carcinoma. Regarding this diagnosis, patient was referred to an oral and maxillofacial surgeon, and resection of the lesion with 1 centimeter safe margin and extraction of first maxillary molar was done. Frozen section analysis was done to ensure not involvement further than safe margins. Okay, we had an squamous cell carcinoma, and what is this disease? On epidemiologic aspects, oral SCC is the 7th most common cancer worldwide. Its prevalence varies depending on the geographic location and has a high prevalence in the Asia-Pacific region. The most common location of squamous cell carcinoma include the tongue, floor of the mouth, and soft palate. SCC often develops from a precancerous lesion, such as untreated leukoplakia or erythroleukoplakia as a red and white lesion. And the lesion is often painless and detected in advanced stages. What is etiology and risk factors of oral cancer? You must know that the incidence of oral cancer is age-related, which may reflect time for the accumulation of genetic changes and duration of exposure to initiators and promoters. These include chemical and physical irritants, viruses, and hormonal effects. So we have 2 categories of risk factors for squamous cell carcinoma: extrinsic risk factors and intrinsic risk factors. The examples of extrinsic risk factors are tobacco and alcohol consumption, betel nut consumption, human papillomavirus, nutritional factors such as vitamin A or vitamin C deficiency, denture irritation, irregular teeth or restoration, and chronic cheek biting habits. About intrinsic risk factors, mutation in the proto-oncogenes and tumor suppressor genes are intrinsic risk factors. And we have some oral conditions that have potential to transform into oral cancer, include lichen planus, leukoplakia, erythroplakia, actinic cheilitis, and submucous fibrosis. What is the sign and symptoms of oral cancer? The most common symptom of oral cancer is discomfort that leads the patient to seek care and may be present at the time of diagnosis in up to 85% of patients. Other symptoms include dysphagia, odynophagia, otalgia, limited movement, oral bleeding, neck masses, and weight loss that occur with advanced disease. The other signs and symptoms include loss of sensory function, especially when is unilateral, is a red flag that may indicate neural involvement and require that cancer be ruled out. Loss of function involving the tongue can affect speech and swelling. And what is tissue changes that occur with squamous cell carcinoma? Squamous cell carcinoma may be present in different pictures. The lesion may be a red, white, or mixed red and white lesion. And you may see squamous cell carcinoma as change in the surface texture that produce a smooth, granular, rough, or crusted lesion. And you may see the lesion as the presence of a mass or ulceration. The lesion may be flat or elevated and may be minimally palpable or indurated. The high-risk sites for oral carcinoma include the lower lip, anterior floor of the mouth, and lateral borders of the tongue. Oral cancer is great imitator and may represent in several clinical features. As you see in the first picture, you see an exophytic lesion in lateral border of the tongue. In the second picture, you see an ulcer in the floor of the mouth that is squamous cell carcinoma. And in the third, you see an ulcer on the lip, and in the other, you see an exophytic lesion in lateral border of the tongue. That all of these pictures are squamous cell carcinoma. As I say, an unhealing ulcer in the oral cavity may be representative of oral cancer. Lymphatic spread of oral carcinoma most commonly involves the submandibular and digastric nodes and the upper cervical nodes, but can also involve the remaining nodes of the cervical chain. The nodes most commonly involved are those that are on the same side as the primary tumor. Also, the closer the tumor is to the midline and the more posterior in the oral cavity or oropharynx, the more common are the involvement of the bilateral and contralateral nodes. And we have a concept that its name is sentinel node concept that say that lymphatic drainage passes from the primary tumor to the first echelon lymph node or sentinel node before draining to the remaining lymphatic basin. But in advanced primary tumors, extensive infiltration of lymphatic channels by tumor blocks freeze the passage of lymph and radio tracer to the true sentinel node. So redirection of lymph resulting biopsy of a different node, which may not accurately reflect the disease status of the remaining nodal basin. About the histopathologic features of oral squamous cell carcinoma. For diagnosis of oral squamous cell carcinoma, dysplasia involves the full thickness of the epithelium and the basement membrane is violated. Dysplasia describes a range of cellular abnormalities that include change in cell size and morphology, increased mitotic figures, hyperchromatism, nuclear size and nuclear cytoplasmic ratio, and alteration in normal cellular orientation and maturation. Well-differentiated carcinomas remains some anatomic features of epithelial cells, including the ability to produce creatine, whereas poorly differentiated carcinoma loses the anatomic pattern and function of epithelium. Tumors may be associated with a mixed inflammatory infiltrate. These are the histopathologic features of the squamous cell carcinoma. And what is the treatment of oral carcinoma, oral SCC? Treatment planning of oral squamous cell carcinoma depends on cell type and degree of differentiation. And it also depends on the site and size of the primary lesion and the ability to achieve adequate surgical margins, and also the presence or absence of metastasis. Treatment planning also is based on lymph node status and the presence of local bone involvement. And also it depends on the ability to achieve adequate surgical margins and the presence or absence of metastasis. Treatment decisions are also impacted by appraisal of the ability to preserve oropharyngeal function, including speech, swelling, and aesthetic, as well as the medical and mental status of the patient. The first treatment plan of squamous cell carcinoma is surgery, and after that radiation that are used with curative intent in the treatment of oral cancer. And in more advanced cases, chemotherapy and targeted therapy are used together with the principal therapeutic modalities of radiation and surgery, and is not considered the benchmark for management of advanced disease. And prognosis of squamous cell carcinoma. The most important predictors for survival of oral cancer are the presence of HPV and a stage of disease at diagnosis. But unfortunately, the majority of oral cancers continue to be diagnosed in advanced stages after becoming symptomatic. Cancers that are positive for HPV, particularly type 16, have a better prognosis compared to HPV negative tumors. Additional prognostic indicators for oral cancer include the depth of penetration, perineural invasion, differentiation level, lymphatic infiltrate at interface, and status of surgical margins. Also, drinking profile, alcohol use, could affect cancer mortality. And overall survival in younger patients is better than that of older ones. And what should we do for prevention of oral cancer? Primary prevention has focused on tobacco as a major cause of head and neck cancers, and attention has been paid to strategies for tobacco cessation. Another way for prevention of oral cancer is HPV preventive vaccination and appeal for reduction in numbers of sexual partners and reduced oral genital contacts. And another way for prevention of oral cancer is oral cancer screening that result in early detection and improve survival in SCC patients. So dentists have a critical role in screening and early diagnosis of oral cancer. And as you see, early diagnosis of oral cancer has a great impact on early detection and prognosis of the patient. So a dentist can survive the patient's life by intraoral examination. After the COVID-19 pandemic, I invite you to travel to Isfahan. It is a very beautiful city, and visit this city. Thank you very much. Have a good time. Okay. We have some question. One question is that maybe he has gingival infection. Gingival infection does not present as an ulcer. As you see in this picture, you see an ulcer and other sides of the gingiva of the patient is in healthy, is health, and also panoramic and periapical examination showed no evidence of gingivitis or periodontitis. So gingival infection is not considered as a differential diagnosis. Another question is that can we recognize the tumor and swelling because of information by touching that part? Yes, as you see, squamous cell carcinoma have some tissue changes in the oral cavity, that these tissue changes guide you for diagnosis of the lesion. And these are tissue changes of the squamous cell carcinoma, and just you can't, squamous cell carcinoma is an epithelial carcinoma. So you must see tissue changes for the lesion, and just touching a part doesn't lead to diagnose a squamous cell carcinoma. And thanks very much for your attention. Okay, we start the third part of oral medicine session by Dr. Mahdi Sadat Musavi. She is Associated Professor of Oral and Maxillofacial Medicine Department, Tehran University of Medical Science. Hi, Dr. Musavi. Thank you very much for your participation. Please start.
Thank you, Dr. Tufai. Good afternoon, everyone. We are so glad you are here with us in the virtual winter school. Today, I'd like to talk to you about cryotherapy in oral lesions. Is it okay? I would like to share with you some of my experiences in using cryotherapy, and I have limited my speech to one real subject treated with this treatment. The years, and his chief complaint was white lesions in the mouth. As you can see in clinical view, the lesion was a white block on the buccal mucosa that extended about 2 centimeters. The differential diagnosis based on the risk factors and the clinical manifestation was oral verrucocarcinoma, oral SCC, and oral leukoplakia. An incisional biopsy was taken from the posterior part of the lesion, where most of the texture changes were seen, for ruling out the possibility of dysplastic changes. And on histopathologic examination, benign hyperkeratosis was reported without any dysplasia. So the final diagnosis was benign hyperkeratosis, which means oral leukoplakia. The treatment for this patient consists of elimination of the stimulating factor such as candidiasis with antifungal therapy that can be nystatin mouthwash, consultant with a specialist to control diabetes, and removing remnant hyperkeratosis. For doing this, we have options like blade surgery or removing tissue with cryotherapy. Let's now turn to some basic points about cryotherapy. Cryotherapy is the deliberate destruction of tissue by application of extreme cold. And for removing specific lesions, we can use this treatment. The gun attached to a nitrogen capsule and is able to freeze tissue. Why cryotherapy? It's painless because neural transmission is immediately blocked by low temperature, and tissue salvage occurs at temperature at or below 20 centigrade, and the temperature of the lesion rapidly recovers when cryosurgery is stopped. So it's well received by patients to a relative lack of discomfort. And the absence of bleeding and minimal to no scarring is a good point for this treatment. Complication after cryosurgery, such as hyperemia, swelling, mouth pain, and erosion are expected but can be typically cured without problems. Most of the patients don't need any analgesia. Therefore, cryosurgery is considered a simple and a safe treatment method. As a conclusion, clinical advantage can be the ease of application, a very low incidence of infection, can be repeated without permanent side effects, and its usefulness in patients for whom surgery is contraindicated due to either age or medical history. So in our patient with a history of smoking and diabetes, it can be a better choice instead of blade surgery. About mechanism of action for cellulose after freezing, I can explain that this abrupt temperature change promotes the formation of ice crystals in the extra and intracellular components of cells. So an osmotic gradient caused by extracellular ice crystals causes the loss of intracellular water. This results in toxicity due to the abnormalities of intracellular and extracellular electrolytes and subsequently cell death. Another mechanism of action for cell death is immunologic effects, and this procedure can stimulate the host's immune system. Generally, oral mucosa is an ideal site for this technique because of its humidity and smoothness. Cryotherapy has been used in the treatment of various lesions such as keratotic, hyperplastic, granulomatous, vascular, pigmented, and salivary gland lesion. Because the freezed tissue is not suitable for histological examination, generally histological examination is required before the cryotherapy to confirm the lesion diagnosis. Currently, there are two main cryotherapy systems, open and closed, for delivering cryogens. The open system achieves the decrease in the tissue temperature via the direct application of cryogen, which is generally a liquid nitrogen, to the tissue by swab or a spray applicator. By comparison, the closed system used a complex instrument known as a cryoprobe, and it facilitates a more controlled delivery of cryogen and permit effective administration of freeze cycle. Also, this system requires costly and complex equipment, but this accuracy makes it highly suitable for intraocular use. We have different probes for cryotherapy that can select based on the lesion size and the site of the lesion. Use of these probes is easier with more control in the oral cavity than nitrogen sprays. Now let's turn to some clinical study about cryotherapy in oral lesions. Here you can see karyotype applied to hemangioma on the right buccal mucosa of a patient during the freezing process. And after that, you can see immediately after the freezing process, the depth and the size of freezing obtained with a nitrous oxide cryoprobe. Because surgical procedure is not easy for preschool children or for elderly patients, the purpose of this study was to analyze cases where cryosurgery was applied to mucosales on the lips or buccal mucosa, and to confirm the efficacy of cryosurgery for lesions caused by minor salivary glands. They concluded that cryosurgery is effective for mucosales of the lip and oral mucosa, and is a very simple and a safe treatment method, especially for preschool children. Let's turn back to our case, and for removing the remnant hyperkeratosis and the buccal mucosa, we decided to use cryotherapy. You can see here 5 days later after the cryotherapy, and it's the healing process in the buccal mucosa. In 2 weeks later, you can see that most of the tissue turned to normal mucosa, and the remnant hyperkeratosis on the commissure of the lip need to be removed by cryotherapy for one other session. We can conclude that cryosurgery effectively eliminates intraoral hyperkeratosis with minimal discomfort, and it's a very safe, easy to perform, and relatively inexpensive technique for treating various oral lesions in outpatient clinic. you very much for participating in our virtual winter school, and I am here to answer your questions.
Thanks a lot, Dr. Musavi. We have some question. One question is that on picture C, was the reaction after cryo? Can you hear me, Dr. Musavi?
Yes, but I should turn back to my PowerPoint.
Okay.
Okay. About picture C, it's the ulcer after the cryotherapy, and it means that the healing process is now is going to recover the normal tissue. And it's one of the normal reaction after the cryotherapy. It's the ulcer with a fibrinoleucocytic membrane.
Thanks very much. Another question is that can we consider laser therapy in such cases too?
One of the important differences between a cryotherapy and a laser is that we can use cryotherapy in any lesions that maybe we can consider them as a perimalignant or lesions with a dysplastic changes. But when we want to use lasers, nowadays and up to date, we can say that we should be sure about the absence of any dysplastic changes and a tissue. But in cryotherapy, we don't have any limitations such this one.
Thanks. The other question is that you prefer more cryotherapy than laser?
It's based on lesions, and it's not a universal rule for all the oral lesions. For malignant and perimalignant lesions, or I can say that in lesions that you expected the dysplastic changes, it's better that you don't use laser. But we don't have such limitations in cryotherapy. So in such cases that, like this case that we have reviewed with each other, that we have keratotic lesions that we can consider that the possibility of the dysplastic changes are common in such cases, the cryotherapy is preferred.
Thanks a lot, Dr. Musavi.
You're welcome.
Thank
Have
you
a nice
for
day.
a nice presentation and have a good time.
Thank you.
Now, you're welcome. Now we have a break, and after that, presentation of Dr. Okay, The next presentation is by Dr. Nafise Sheikh Bahai. She is Assistant Professor of Oral and Maxillofacial Medicine Department, Tehran University of Medical Science. The topic of lecture is physical therapy modalities for temporomandibular disorders.
Among physical therapy modalities, thermal therapy and colon therapy do not need to a special device. Accordingly, we talk about into approach, but other physical therapy such as TUMS or laser or US need to a special device and equipment, and therefore we do not speak about them.
Okay, I apologize for the problem. Now we have the PowerPoints of Dr. Nafise Sheikh Bahai, Assistant Professor of Oral Medicine Department, Tehran University of Medical Science.
In the name of God, hi everybody, welcome to this virtual course. I am Dr. Sheikh Bahai, Assistant Professor of Oral and Maxillofacial Medicine Department of TUMS. I'm very happy to talk to you in this part of the program. I hope the corona pandemic will be controlled as soon as possible, and you can travel to Iran and see you face to face. In this part, we want to speak about the case with temporomandibular joint disorder and the non-surgical approaches to treatment it. We only, in this part, introduce and talk about methods that do not require a special device or equipment in office. And in most of them, the patient is primarily responsible for treatment. Okay, let's go to case presentation. A patient referred to oral and maxillofacial medicine department with pain and tenderness in front of ear and face in right side, and she has limitation in mandibular movement. The first step in the treatment of any patient is an accurate and correct diagnosis. We should take complete information about the patient's chief complaint. For example, location of pain, onset of pain, characteristics of pain, and aggravating and alleviating factors of pain, past treatments, relationship to other pain. Then take past medical history, review of systems, and assessment the psychological factors. After this, we examine the joint and other relevant masticatory muscles. According to our examination, she has the temporomandibular joint disorder. We rule out odontogenic pain and such systemic disease such as rheumatoid arthritis, but she had diabetes mellitus and peptic ulcer. Pain was intermittent, and the onset of pain was from 2 months ago in masseter, temporal, and medial trapezoid. We see pain. The visual analog scale of the pain was 5 to 6. She had a soft end limitation in mouth opening and deviation to right side in mouth opening. Tenderness during intra-articular TMJ palpation reveals capsulitis. Also, she repeated headache and pain in neck. Pain aggravated with chewing and speaking and urine yawing. She is a stressful person with parafunctional habit, clenching during the day and nocturnal bruxism. Okay, according to our examination, the type of TMD was myalgia with subtype of myofascial pain with referral. We have pain in masticatory muscles and pain modified by jaw movement, function or parafunction. And she has referred pain to head and neck with muscle palpation. Also, she has trigger points in masseter muscles. There are many problems and challenges in treatment of TMD because identification and elimination of etiologic factors in TMD are very difficult. The treatment that the dentist choose must be relatively accessible, inexpensive, safe, reversible, and also combining treatment have better outcomes, and conservative non-surgical treatment are the first level of treatment. Okay, according to our examination, in this slide, you can see the non-surgical technique for treatment of TMD, and we talk about some of them that do not need to any device or equipment. The treatment techniques have two main categories. Definitive therapy is aimed directly at eliminating or altering the etiologic factors responsible for the disorder, for example, education, self-care, and cognitive behavior therapies. But symptomatic or suppurative treatment only relieve the pain and often have no effect on etiology of the disorder, such as pharmacology. When a patient comes to the dentist with symptoms of TMD, the first treatment is to educate the person regarding the nature and source of the pain, symptoms of TMD, closely relationship between emotional stress, muscle hyperreactivity, and parafunctional activity and TMD problem. It is important to tell the patient the most TMDs are benign and not aggressive disorder. Once they understand the problem, anxiety will be reduced, which often reduces the pain. Parafunctional activity occurs almost entirely beneath the level of consciousness. Therefore, patients are generally unaware of it. Establishing an awareness of non-functional tooth contacts, muscle hyperreactivity, and emotional stress is essential to effective treatment. Also, patient must be educated about diagnostic and treatment approaches, and she must know that the main and important role of herself in effective treatment. Another definitive treatment that I believe that it is the most effective treatment in TMD patients is self-care. Education is the basis for self-care activities. Control oral parafunctional behavior is the most important self-care in TMD patient. We say the patient be aware of and control oral parafunctional behaviors. Teeth should only contact during chewing and swallowing. Monitor jaw at regular intervals throughout the day from any clenching, grinding, touching, or tapping of teeth or any tensing or rigid holding of the jaw muscles. We train the patient to practice rest jaw posture or freeway space. She must place the tip of the tongue behind the top teeth or in the floor of the mouth. Separate the teeth slightly and allow the jaw to hang in this position. Maintain this position when the jaw is not being used for functions such as speaking or chewing. Another self-care is modifying the food texture in her diet. Choose softer food and only those food that can be chewed without pain. Cut foods into a smaller piece. Avoid foods that require wide mouth opening. And do not chew gum. Also, the patient must avoid certain position or movement. We say to patient, do not lean on or cup the chin when performing desk work or at the dining table. Do not test the jaw by opening wide or moving the jaw around excessively to assess pain or motion. Avoid habitually clicking the jaw if the click is present. Do not sleep on the stomach or in posture that place stress on the jaw. Avoid elective dental treatment while symptoms of pain and limited opening are present.
ببخشید کمک به من میکنی؟ زوم چرا باز نمیشه؟ اوکی درست شد.
Because our patient is a stressful person, cognitive behavior therapy or CBT techniques can help her to reduce stress and anxiety. We cannot remove or eliminate stress completely, but we can reduce and manage it. Two types of relaxation therapies can be applied to reduce levels of emotional stress. substitutive and active. In substitutive relaxation therapy, we encourage patients to remove herself when possible from a stressors and to substitute other activities that she enjoyed, such as allowing more time for a sport or hobbies. In active relaxation therapy, directly reduce muscle activity by regular periods of time away from the stressors. Another relaxation technique is progressive relaxation. And this technique is an instructed exercise that involves learning to constrict and relax the muscle groups systematically, beginning with the face and finishing with the feet. Because our patient has pain, tenderness, and limitation in function because of muscle spasm, supportive therapy has indication. And these approaches often have no effect on the etiology of the disorder and only are symptomatic. Before the clinician prescribe a medication, she or he must be familiar with the proper dosage, indications, contraindications, and potential adverse effects of the drugs. Since many TMDs present symptoms that are periodic or cyclic, there is a tendency to prescribe drugs on a take as needed basis that decrease many side effects such as drug abuse. When drugs are indicated for TMD, they be prescribed at regular intervals for a specific periods, and it's better for the patients. The most common classes of pharmacologic agents used for the treatment of TMD are analgesics, anti-inflammatories, muscle relaxants, anxiolytics, antidepressants, and anti-convulsive drugs. In next tables, you can see the most common drugs in each class, average and maximum dose daily. Often we start treatment with a minimum or low dose and if we did not see a good effect, increase the dosage. The most common analgesic and anti-inflammatory drugs are NSAIDs. Naproxen is a good medication in TMD patients, especially in patients with cardiovascular disorder. Because our patient has a peptic ulcer, naproxen will be administered with the PIP proton pump inhibitor and take with food for less than 1 week. Or we can administer COX-2 inhibitors such as celecoxib. Opioids such as codeine, hydrocodone, and tramadol are for moderate to severe acute pain, and it seems that has no indication in this case. Antidepressant is another category of drugs because our patient has diabetes mellitus, TCAS, such as amitriptyline has contraindicated, and SSRIs such as fluoxetine has contraindicated because perhaps increased bruxism, and our patient has nocturnal bruxism. Two types of relaxation therapies can be applied to reduce levels of emotional stress, substitutive and active. In In substitutive relaxation therapy, we encourage patients to remove herself when possible from stressors and to replace other activities that she enjoys, such as sport and other hobbies. In active relaxation therapy, directly reduce muscle activity by regular periods of time away from the stressors. Okay, in this slide you can see an example of a prescription for our patient. For thermotherapy, we ask the patient to lie a hot, moist towel over the symptomatic area in masseter and temporal muscle and for thermotherapy, we ask the patient to lie a hot, moist towel over the symptomatic area in masseter and temporal muscle and over the TMJ area. A hot water bottle over the towel will help maintain the heat. Also, she must keep the towel 10 to 20 minutes, not to exceed 3 minutes, twice daily. Coolant therapy is effective in acute and chronic problem and pain. For coolant therapy, an ice pack is applied to the painful area for 2 to 4 minutes or until the tissue feels numb. Then the tissue is allowed to slowly warm again. This can be repeated as needed 2 or 3 times a day. Ice should not be left on the face for longer than 5 to 7 minutes because tissue injury may result. Another treatment approach for TMD patients and our patients is manual techniques. These techniques are the hands-on therapies. We can train the patient to massage her painful muscle. Superficial massage lead to mild stimulation of cutaneous sensory nerves, exert an inhibitory influence on pain, and deep massage causes to increasing blood flow to the area and eliminating trigger points. Passive muscle stretching of painful shortened muscle can be effective in managing some TMDs. For correction the deviation, we ask the patient to open on a straight opening pathway, watching herself in a mirror 2 to 3 times each day and 10 repetitions. Pain and sound should be avoided in this movement. movement. When there is a need to regain muscle length, for example, in our patient that she has a limitation in opening the mouth, assisted muscle stretching is used. The stretching should never be sudden or forceful. The stretching force inserted gently and intermittently to the elevator muscle with the fingers or increased number of upslung. Every 3 days, one upslung added to previous upslungs, and she must apply upslungs 3 times a day, each time 10 to 15 minutes. Pain should not be elicited in this approach. In resistant exercises or isometric exercise, according to concept of reflex relaxation, the opposed muscles will be relaxed. We ask the patient to move mandible against gentle resistance provided by the fingers. These exercises are repeated 10 times each session and 6 sessions a day. If they elicit pain, they are discontinued. Our patient had referred pain in head and neck. Certainly, the referred pain caused by central sensitization that are major contributors. But some others have also suggested that the posture of the head and neck and shoulder can contribute to TMD symptoms. This forwarded and rotated head position produce elongation in the supra and infrahyoid muscles. And training to keep the head in a more normal relationship with the shoulders may be helpful in reducing TMD symptoms. According to individual condition of each patient, we can apply several of these treatments with no need to any special equipment or device. I hope that this information can be useful for you to treatment the TMD patients. Thank you for your attention.
Okay, thanks a lot for your attention. The oral medicine session in this part has been, this was the last presentation of oral medicine session. I hope that these presentations was useful for you, and thanks a lot.